Hello everyone, hope you all are doing fine. So today I am here with lecture 6 of my ECG simplified medical study series, and this lecture is about the P wave and its relation to the atrial abnormality. I hope you have gone through all the 5 lectures of my ECG simplified medical study series, and let us start today with the 6th chapter, that is P wave and atrial abnormality. And on the same note, enjoy the coffee and learn the ECG. So before commenting on whether P wave is normal or abnormal, we need to see some of the features of the P wave. Number 1, the P wave normal morphology we all should know. It is always upright, it is smooth, rounded, 3 small square broader, 2 to 3 small square taller, and in all the leads it is monophasic, except in lead V1 it is biphasic, and in AVR it is inverted. So this P wave is to be seen mainly in lead 1, 2 for normal upright feature of the P wave. For biphasic feature we need to see V1, and for inverted P wave we need to see AVR where it is normally inverted. Then sometimes the displacement or wrong placement of the leads may show some abnormal waves, or may show some waves as abnormal, but in actually they are not abnormal, but they have been recorded wrongly because of the wrong placement of the leads. So for that there are 1 or 2 tips I am telling you. One is, if any of the lead in lead 1, 2 or 3 you see a very flat line ECG or a very low amplitude complexes as compared to other leads, consider the leads are wrongly placed. Number 1. Number 2, if in lead 1 P, Q, R, S, T are inverted, because in lead 1 P, Q, R, S, T are always positive, but if in lead 1 P, Q, R, S, T are inverted, and from V1 to V6 we see the normal ECG pattern, that is normal R wave progression from V1 to V6, then it is also because of the wrong placement of mainly the arm leads, and here AVR also become positive. We will see how you will be able to understand by this. Now you all know ETH1 triangle. See, this is the ETH1 triangle consisting of lead 1, lead 2, lead 3, where lead 1 is the potential difference between left arm and right arm, lead 2 is the potential difference between left leg or left foot and right arm, and lead 3 is the potential difference between left foot and left arm, and right arm AVR, left arm AVL, left leg AVF. Now suppose the right arm lead is placed on left arm and left arm lead is placed on right arm, then the situation will be like this. Now you see the left arm lead has been placed on right arm and right arm lead has been placed on left arm. Then what kind of ECG pattern we will see? Now the ECG pattern will be little different from the normal ECG pattern. The lead 1 in actual measures the difference between left arm and right arm, that is left arm minus right arm. Here it is now opposite. So in lead 1 we will see the inverted waves. Actually in lead 1 there are all the waves are positive, but when the arm leads are wrongly placed, the lead 1 will become inverted, because now it will measure the difference from right arm to left arm, right arm minus left arm, so lead 1 will become inverted. Now lead 2 difference will be now left foot minus left arm, so this lead 2 difference which will be left foot minus left arm, this lead 2 now will become like lead 3, so it will be somewhat negative, and lead 3 difference will be now left foot minus right arm, which will be something like lead 2. So lead 3 will become lead 2, lead 2 will become lead 3, and 1 will become inverted. So ECG will be something like that. The 1 will be inverted because of the wrong placement of the leads. The lead 2 will show the changes like lead 3 because of this difference, which will be inverted form, lead 3 will be like lead 2 wave. So this is the way you will find out that the leads are wrongly placed. And another characteristic finding in normal ECGs, AVR is always inverted. Whenever you see AVR is positive, consider the first most common problem is with the wrong placement of leads. So if AVR, now this will become AVL, this will become AVR, and now the right arm will record a positive deflection and left arm, that means the AVL, will record the negative deflection. So this is the way you can find out just by this feature that AVR has become positive. You can know that the leads are wrongly placed unless other findings supporting this. Now in all the leads where P wave is monophasic, the left half of the P wave represents the right atrial depolarization and right half of the P wave represents the left atrial depolarization. And in V1, when the P wave is biphasic, the left positive deflection will represent the right atrial depolarization and this right negative deflection will represent the left atrial depolarization. So remember, the P wave is divided into two forms. The left half of P wave represents atrial depolarization because it depolarized earlier. Then the wave moves to left atria, left atria depolarized, and so right half will represent the left atria. Similarly in V1, this will be right atrial depolarization and this will be left atrial depolarization. Now abnormal P wave. What actually is the abnormal P wave? As you know, normal is rounded, upright, smooth. 3 small square broader, that will be 0.1 seconds, and 2 to 3 small square taller, that will be approximately 0.3 or you can say 0.25 millivolt. So as P wave is this much broader and this much taller, any change in the width or in the height of the P wave will be abnormal. And what kind of change? If P wave is larger than 0.12 seconds and larger than or equal to 0.3 millivolt in height, that is 2.5 millimeter in average, then the P wave will be abnormal. So it will be abnormal when it will be of 0.12 second, that is more than 3 small square, and 0.3 millivolt or equal to 0.3 millivolt, that is around 3 small square taller. So that P wave will be abnormal. Now how to find right atrial overload? By seeing the P wave. As right atrium is denoted by left half of the P wave, so whenever there will be overloading of right atrial or right atrial enlargement or problem with the right atrial depolarization, the left half of P wave will become abnormal. So when it will be monophasic, the left half of the P wave will become enlarged. It will enlarge to form a tall tented P wave, and the P wave will become more than equal to 3 millimeter in size. So it will be something like this. The right half of the P wave has enlarged because of the enlargement of the right atrium, and the P has become tented or taller. It is somewhere more than or equal to 3 smaller squares upright. So this is the way we see the right atrial enlargement by seeing the morphology of the P wave. P wave in lead V1, where it is biphasic, the upper half of P wave, which represents the right atrium, will become taller and negative component will remain the same. So it will be something like that. The left half, this right atrial component enlarges, left atrial component remains the same. The width here in such kind of abnormality does not alter. So whenever there is a right atrial enlargement, there is an enlargement of the P wave, but its width does not alter. It is to be best seen in 2-3 AVF and lead V1. And this kind of tented P wave or taller P wave of right atrial enlargement is known as P pulmonale. Clear? So P pulmonale is tented P wave or represents right atrial enlargement, or where you can say whenever there will be a pulmonary abnormality, the right heart, or there is a overloading of the right heart and right ventricle to right atrium pressure, and then leads to the right atrial enlargement. That is why it is something it is said as P pulmonale. Now let us start by ECG. Here you see the P wave in biphasic P wave, smaller upward deflection, smaller downward deflection, maximally to 1 millimeter. So this is the normal P wave morphology. So when this will become abnormal, you see the tented P wave. The P wave from rounded shape has become a tented. This is the tented P wave. 2 lead 3 lead ABF. This is the tented P pulmonale. So this denotes the right atrial enlargement. Now causes of right atrial enlargement, right atrial overload. All the causes which affect the right ventricle will affect the right atrium, and right ventricle is affected by the changes in the pulmonary structure. So all the complaints of the cor pulmonale, or all the causes of the cor pulmonale, will be the cause for the right atrial enlargement. So they will be COPD, asthma, emphysema, pulmonary embolisms, and congenital heart diseases like ASD, tricuspid regurgitation, and pulmonary valve stenosis. There will be pressure changes in the right atrium and it will enlarge. So most common cause of right atrial enlargement is right ventricle problem. Now left atrial overload or left atrial enlargement. So in this case, the right half of the P wave will become abnormal whenever it will be monophasic, and in biphasic condition the negative half of P wave will become abnormal. Here there will be delay in the left atrial depolarization because of the enlargement or overloading of the left atrium, and because of that delay, here the duration of the P wave will change. In earlier condition the duration was not changing, the change was the length, the height. Here the height will not be so much in abnormal shape, but the duration will change because the left atrium has enlarged and it is taking more time, or the wave of depolarization taking more time to depolarize whole of the left atrium. So as left atrium is denoted by right half of the P wave, here the right half of the P wave extends and the width of P wave change to form a broader P wave and notched P wave. So P wave here will be more than 3 millimeter broader, that is more than 0.12 seconds, and the notched P wave, which I have said, it will be something like this. So the distance between the notches will be of 1 millimeter, that is 0.04 seconds. So this is the notched P wave, and it will here in V1 the positive component will remain same, negative component will expand and or you can say will become broader. So it will be more than 0.04 second and more than 0.1 millivolt negatively, and here it will be more than 0.04 second. The width, so here the width alters but the height does not alter. So you just make it like width alter but the height does not alter. Best seen in lead 2 and V1, and this M pattern P wave is known as P mitral. So this is P mitral. So it is to be taken like whenever there will be a problem with the mitral valve, the pressure changes will be on the left atrium and left atrium will become overloaded and enlarged. That is why this this kind of pattern of P wave is termed as P mitral. Now let us see two ECG patterns. Here you see the broadness of P wave, the notch of the P wave in lead 2. This is the P wave broadening and notching of the P wave. In lead V1, the negative component has become enlarged more than one smaller square. So this is the way we can see the P abnormality for the left atrium. This is the left atrial enlargement ECG. You just see lead 2 where the width of the P wave has enlarged or the duration of P wave has increased, you just see the V1 where you can see the duration of P wave has increased, and also it is more than 0.1 millivolt and more than 0.04 second. So this is the way the P wave will look like in cases of the left atrial enlargement. So condition associated with the wide P wave or left atrial overload or left atrial enlargement. Remember, all the condition which causes the left ventricular enlargement will affect the left atrium. So remember the causes for left ventricular enlargement, they will be the same for left atrium, and the most common cause for the left atrium problem is left ventricle, or left atrial enlargement is left ventricle. So the causes will be hypertension, valvular heart diseases, congenital heart diseases, cardiomyopathy, coronary artery disease. In coronary artery diseases, sometimes the P wave will become widened without any change in the left atrium. So the widening of the P wave in coronary artery disease just denotes because of the change because of the coronary artery, not because of the left atrium. Okay. And remember, P wave is of very limited sensitivity and specificity for arterial enlargement. So to make a definitive diagnosis of arterial enlargement, go for echocardiography. Thank you so much for patiently listening. If something is not clear, please be frank to ask. You can send your queries in the comment section, and I promise that you will be replied. Thank you so much for listening. Keep smiling. Thank you.